All right, so I just want to throw a disclaimer out there. I am not an expert and a know-all of everything. So if you guys have any questions and I can't get the answer to you tonight, I will gladly get back with you with it. But unfortunately, I don't know everything. And some of these slides I'm going to go through really quickly. Chance emailed them out, so you guys have a copy so you can refer back. And I'll be glad to answer any questions via email through the course or through my UAB email if you guys have any questions that we don't get to tonight, or for the people that are reviewing it later that aren't actually here. All right, so pharmacokinetics. Absorption, distribution, metabolism, excretion. You guys have had all of this in patho previously, but it's really important to how medicines work, right? So specifically metabolism, I'm going to focus on quite a bit. So of course you have metabolism through the liver, and you have phase 1 and phase 2. Phase 1 is where the CYP450 enzymes come in. And then there's also an enzyme called UGT that's through phase 2, and some drugs go through that. It's kind of similar to the CYP450 as far as concepts. And then of course you have all the other metabolism sites, but I'm going to talk a lot about the liver. All right, so it's the major enzyme system that's produced in the liver to break down drugs. 90% of drugs are metabolized by CYP450 enzymes. 90%, that's a lot. There are 6 main enzymes. Really, the ones that we deal with in mental health are, there's 5 of them: 1A2, 2C9, 2C19, 2D6, and 3A4. I actually had to look it up before to see what 2E1 was, and actually there are 2 medicines that I found that we might deal with, and that's zopiclone and S-zopiclone. So some people are super fast metabolizers of certain CYP enzymes, so they don't often experience side effects, but they also don't really get the effectiveness that other people would get. And you also have people who are slow metabolizers, which typically have more side effects, and they're not able to tolerate medications as well and might need a decreased dosage of medicines. And kind of the rule of thumb is if they have 2 actual adequate trials of medications and they don't respond well, then you might want to consider genetic testing.
Hey, Andrew, can I jump in real quick?
Yep.
Well, you can leave
Absolutely.
it right there. So just real quick, just so I know. So do you guys know what each one of these 3, like the 2D6, do you know what they represent? Or do they just seem like arbitrary numbers? All right, so the first one, so in this case, like 2, it's like family. D is what they consider to be subtype, and 1 is the gene product. And we can move that for a conversation another day, but those numbers actually have meaning. They're not just randomly thrown together. But I was just checking. Since you guys don't have any information on that, I probably should leave it alone.
All right, so I have no good way for you guys to memorize this. And it's something that you could look up if you don't know the answer to, which I do often. But it's good to know like the big medicines that we use and what enzymes they affect so that you know why a person is or is not reacting to a medicine. And so the ones that are underlined are the primary substrates for that medicine. And if a medicine doesn't have one underlined, then they kind of are all in there equally. So this is not an exhaustive list. This is just the common ones. There's lots of other medicines not listed here. So I have the antidepressants, and then TCAs, benzos. Most of the benzos are all 3A4. So that's really the main one you need to know for that. And actually, let me go back a slide for a second. So Prozac is 2D6 and 2C19. The 2C19 blockade is what is responsible for the kind of, what am I trying to say? Like the restlessness that sometimes Prozac can cause when you first start it. It's because of 2C19 that it does that. And typically, if they have that initially, they'll typically respond well to that medicine after they've been on it for a couple months. So TCAs, a lot of 2C19, 2D6, benzos 3A4. Most of the typicals have 2D6. And then the atypicals are really kind of scattered between 1A2, 2D6, and 2C4, 2C19. So do you guys actually know what it means as far as if someone is a rapid metabolizer or a slow metabolizer, and how you should change medications depending on if you get genetic testing?
Kelly says rapid metabolism needs higher dose.
Yep. So that's one of the things that you could do if you have a rapid metabolizer is elevate the dose. Yep. Or lower the dose if they're slow metabolizers. Or also consider, yes, changing the medicine to one that they might be more receptive to. And I don't know if you guys have ever seen genetic testing, but often it's coded with like a red light, a yellow light, and a green light. The red light doesn't necessarily mean that you cannot use this medicine. It just means that, you know, they're less likely to be responsive to that medicine. So let me.
So let me throw out something real quick because we had talked about like reduced activity or poor metabolizers. So does anyone know what the CYP enzyme is that a percentage of Asians tend to be poor metabolizers of? It's on the screen somewhere. No. Okay. So the 2C19, about 20% of Asians are actually poor metabolizers there. And so they obviously have to sort of piggyback on what Andrea was saying. They have to metabolize by alternative routes. And so they, often have elevated drug levels in their bloodstreams and their brains compared to other individuals with, with normal enzyme activity. But it's good to know if there's certain, ethnic percentages, particularly in that case where 20%, you probably are not going to choose a medication that is metabolized 2C19 if you're treating someone who is Asian. I guess that's my point. So those things are kind of good to know. I think, and correct me, Andrea, it's like what, 5 or 10% of Caucasians are poor 2D6 metabolizers, something like that.
Yeah. And I
Yeah.
actually touched more on that on the mood stabilizer thing, talking about mood stabilizers and a dosage adjustments and needing to do genetic testing.
Okay.
And I just want to throw this out there because I thought it was interesting. For aripiprazole, people who are poor 2D6 metabolizers have a 60% increased active drug exposure. So that's a lot. As you can imagine, they probably have a lot more side effects at lower doses if they're poor metabolizers. So it really does matter. This is really stuff that you need to know. It's not just a whole bunch of numbers and letters and you'll get to it later kind of thing. All right, so pharmacokinetic tolerance. That's when the liver started to metabolize the drug more effectively. Pharmacodynamic tolerance is when there's kind of down regulation of receptors or receptor desensitization. Enzyme induction. Your liver produces more enzymes because of taking the drug on a regular basis, which typically starts 1 to 3 weeks after you start a medicine. I gave an example of drinking alcohol, and it takes 1 to 3 1 to 3 weeks for your liver to break down alcohol faster. So that's what leads to, dependence and tolerance of alcohol. And then alcohol dehydrogenase is one of the enzymes that breaks down alcohol in the gut. And females have a lower amount than that, which is why the drinking limits for women and men are different. All right. Do you guys have any questions about that? I'm just trying to breeze through some of this because some of this you've had in other classes before, and it's just kind of a brief refresher because it ties into other things later in the presentation. So this is where I might lose some people. Please try to stay with me. Ask questions if you have any. Sure. What's that?
Okay, I'm just going to unmute. Can you hear me?
Okay. Yep.
Okay, so yesterday when I was in clinical, the physician I was working for, one of the patients, we were going through so many, I don't even remember exactly the exact drug, but it was an antipsychotic. He had me like quickly look up, because he wanted to change it, and he had me quickly look up like which enzyme, it was, because what he was going to change the patient on was also, it was like the same enzyme, so he chose a different medication. But like I wasn't following why he did that, and like I said, we were moving quickly, so I didn't ask him why did he do that. Did you understand my question?
So he was on antipsychotic A and he wanted to put him on antipsychotic B until he realized it was the same enzyme, so he put him on antipsychotic C? Yes. Is that what you're asking? Okay. So it goes back to, whether they're responsive to the drug and if they're having side effects. What was the reason of changing him? It just wasn't effective?
I think it was not effective. Yeah.
Okay, so if that's the case, he might have been... Well, so he might have been a rapid metabolizer of that CYP450 enzyme, and so switching him to a different one, a different antipsychotic that affects a different enzyme, he might respond better to. I'm just guessing that he is potentially a fast metabolizer of that enzyme.
Okay. I didn't know if there was like some hard and fast rule about that because I'd never seen that before, but okay, that makes sense.
All right, let me get back here. Okay, so you have, obviously drugs have the desired effects and the adverse or negative effects. And with drug receptors, you have 4 primary receptor families. We only really care about 2 though. Ligand activated ion channels or ionotropic receptors, which is when a ligand gets into the receptor site and opens the ion channel, whether it be sodium or chloride, whatever, and then the ion flows into the cell. And they have excitatory or inhibitory effects depending on the ions. And then there's G protein and second messenger system, also known as metabotropic receptors. And that's a really complicated process that essentially involves changing or altering the products synthesized in the nucleus of the cell. So ligand activated ion channels are large protein complexes, and they have certain regions that are binding sites for neurotransmitters. These are typically going to give you a faster response than the second messenger system, which makes sense because it's a direct pathway. And the kind of multi-step process of the second messenger system means it's like an indirect effect on the ion channels opening and closing. So the protein to which the neurotransmitter binds is not an ion channel. It depends on activation of several different molecules inside the cell via the second messenger pathway. So these have a slower response than the ligand ones because it's an indirect pathway. All right, so just a little review of synapse, parts of the nerve cell. So this little picture up top is a nerve cell and the different parts of the nerve cell, also known as a neuron. And so you have different parts, and these parts are kind of important to know in how medications work. So the synapse is the junction point between neurons. The presynaptic cell is the one that carries the impulse to the synapse. Postsynaptic is the cell that receives the impulse, and Excitatory neurotransmitters cause postsynaptic cells to become more likely to initiate a nerve impulse. And inhibitory neurotransmitters cause postsynaptic cells to become less likely to generate a nerve pulse. So they're kind of like a brake to prevent overproduction of excitatory neurotransmitters to produce a calming effect. So with presynaptic cells, that's when an impulse travels along the cell and reaches the end of the axon, and it causes the cell to release a neurotransmitter into the synapse. And then the postsynaptic cell is when the neurotransmitters diffuse into the synapse and then bind with receptors on the dendrites of the postsynaptic cell. So do you guys know which neurotransmitters are excitatory and which ones are inhibitory?
Martha says GABA is inhibitory. You guys can use the mics if you want to. Kelly says glutamate excitatory.
Yeah, and so glutamate is the most common excitatory neurotransmitter. What other neurotransmitters are excitatory? Yes, dopamine and norepinephrine. And then what other is an inhibitory neurotransmitter aside from the GABA? Actually, acetylcholine can be inhibitory and excitatory depending on the receptor site it's binding to. And dopamine is kind of the same way, also depends, but typically we think of that as an excitatory. The other one is serotonin. All right, let me scroll here. All right, so agonists, partial agonists, all of that good stuff. So agonists is when a drug that fits into a receptor and causes a biological response because they mimic the endogenous neurotransmitters. So natural agonists are substances within the body that have evolved to produce a response when they bind to and switch on a receptor. So agonists mimic those. And there's two main properties of agonists. They have affinity and efficacy. So affinity is the degree of attraction or the rate of binding, and then efficacy is the ability to cause a biological response by binding to the receptor. A partial agonist is when the drug binds to and activates a receptor, but with a lesser intensity than a natural agonist or a full agonist. And sometimes these are known as agonist-antagonists because while they do directly act on receptors, if they're used in the presence of another agonist, then they compete for the receptor and they have partial blocking properties. And so it's kind of like, you guys might remember this from Patho and Farm before, but it's kind of like a lock and key mechanism. The lock is the receptor, the key is the molecule. And when an agonist goes into the key, goes into the lock, the key turns and it opens the lock, right? And I know it might have been a while since some of you guys had these, which is why I'm doing this kind of brief review of some of this stuff. So antagonists, they block or dampen the response by binding to and blocking a receptor. And they block the effects of the endogenous neurotransmitters and oppose normal synaptic transmission. And they have affinity, but they don't have efficacy. And then you have competitive antagonists that bind to receptors at the same binding site as the endogenous ligand or agonist without activating the receptor. And then non-competitive antagonists either bind to the active site of the receptor or bind to an allosteric site of the receptor. And these effects can't be negated no matter how much agonist is present. You guys still with me so far? All right, so here's an example of a partial agonist because people often get confused by these. So we're looking at aripiprazole here. And so the maximal effect of aripiprazole is between that of a full agonist, which is dopamine, and an antagonist, such as Haldol on dopamine D2 receptors. And when you take aripiprazole, it occupies the receptor in brain regions where dopamine is high, and it will partially block the effects of dopamine in that area of the brain. And in brain regions where dopamine is lower, it will act as an agonist to increase dopamine in those regions. So aripiprazole will never fully block dopamine function, which is why it produces less extrapyramidal side effects. And because it is a partial agonist, that's also why it's not super effective for psychosis. All right, serotonin receptors. I know Chance has talked with you guys about this some, and you might have also gotten it in some of your other didactic classes, but it's one of the more common questions I see with the students that I precept. And again, important for you guys to know to figure out, instead of trying to memorize every side effect of every drug, if you know the concepts of why those side effects are happening and know what receptors that they're hitting, then you can kind of generalize it instead of trying to have to remember every little side effect of every drug. So 5-HT1A has to do with addiction, aggression, anxiety, appetite, mood, sexual behavior, sleep. So I have a list of selective agonists and non-selective agonists for that. 5-HT1B has to do with addiction, aggression, anxiety, mood. 5-HT1D, anxiety, locomotion, and vasoconstriction. I'm not going to read like every single one of these to you guys because you have the slides so you can read them. But it's just like a generalization of which serotonin receptors do what so that you know how to kind of group that as far as side effect profiles. And if your patient is having a side effect from drug A, then you might want to go with another serotonergic agent that hits different serotonin receptors. Same concept as kind of what we were talking about earlier with the CYP450 enzymes. 5-HT3 is the one that causes the most GI upset. The function equals what happens when stimulated, and then the opposite when blocked. I'm not sure I understand your question. Oh, you mean the things that I'm listing out?
Hi, I can just talk. I was trying to text.
Okay.
So you list all these. So it says like emesis. Does that mean when 5-HT3 is stimulated, it causes like people to throw up, or that when it's blocked, and then when it blocks, like that is anti-nausea effect? Is that sort of what you mean?
Well, yes, and then so you have to look and see if the drug is an agonist or an antagonist for these things. Does that make sense?
Yeah, that makes sense. That's what I was trying to sort.
Yep, and so like Chance and I were talking about this earlier, Trintellix is really 5-HT3 focused, which is why it causes a lot of GI side effects. So typically with that medication, I started at 5 milligrams and titrate up from there. I mean, you can start it at 10, but I find that people have more GI upset with that, and they better tolerate it and are able to stick with the medication and do better if you start it lower and increase it more slower.
And then some of those side effects will go away with time, right? Like you sort of get used to it.
Right. Yeah, because that has to do with kind of like downregulation of receptors too, and kind of going back to the concept of like the alcohol example, where it takes 1 to 3 weeks for your liver to start making more of the enzyme that breaks down alcohol. So then that kind of thing. Does that make sense?
Yeah, totally.
Okay. Okay. All right. And I actually want to go back one slide. All right. So on the 5-HT2A agonist, you see psilocybin, LSD, mescaline. I put that just for you guys to help like with understanding of. So those are psychedelic medications. Psilocybin is present in psychedelic mushrooms. Mescaline is also known as peyote. It's a natural psychedelic known for hallucinogenic effects like LSD and the mushrooms, and comes from the peyote cactus. So you can, that's why it kind of causes the psychotic symptoms when they use that, and why antipsychotics have the opposite effect. All right. So I'll just let you guys read this case study. 27-year-old male with major depressive disorder and has failed adequate trials of Prozac, Trintellix, and Effexor due to them being ineffective. He's slightly overweight and has prediabetes. Genetic testing is completed, and it shows he's a rapid metabolizer of CYP2D6 and CYP3A4. Normal metabolizer of CYP2C19 and slow metabolizer of CYP1A2. How does this guide your prescribing for this patient? Maybe we should have waited to email the slides out until after. Yep, yep. So finding one that's 2C19, yep. That would be a good option. Alexa, So Celexa is a 2C19 escitalopram and sertraline as well. Avoid 1A2. Why would you want to avoid 1A2? Yep, and yep, increased drug levels, increased side effects. Yep. He would actually likely do best on a trial of Wellbutrin. Wellbutrin is 2B6. And he wouldn't be a good candidate for mirtazapine because, again, he's a rapid metabolizer of 3A4 and 2D6. All right, so how about this one? 38-year-old female with GAD and OCD, failed Zoloft, Celexa, and Vibrid due to intolerable side effects and jitteriness. Has had weight loss due to anxiety, and her BMI is on the low normal side. Genetic testing is completed, and it shows she's a slow metabolizer of 2C19 and a normal metabolizer of 2D6 and 3A4, rapid metabolizer of 1A2. So what do you guys have thoughts about this patient? Why would the Luvox have to be at a higher dose? Yeah, yeah. So if they're rapid metabolizers of the 1 and 2, yeah, you could try a higher dose of the Luvox. That wouldn't be a bad choice. They would probably do best on Paxil though. I mean, she's kind of low normal as far as weight, and Paxil is really great for OCD symptoms, and it's 2d6. All right. So psychobiology. The brain, that's our organ. We should know about the brain. Just like cardiologists should know about the heart, nephrologists should know about the kidneys, we should know about the brain. So do you guys know what part of the brain is affected in PTSD? There's 3 parts. Yep, frontal lobe, amygdala, hippocampus. Yep, that's it. So how I remember this is the amygdala is like your kind of emotional save button. Deals with anger, pleasure, sexual arousal. Hippocampus is like your memory save button, long-term memory, etc. And then your prefrontal cortex, of course, is with executive judgment and reasoning. On scans, we can see that there are changes in these areas of the brain in people who have PTSD versus ones who don't. Do you guys know the parts of the brain that are impacted with depression? Amygdala, uh-huh. Yes, it can be different for different people, and it does depend on symptoms, but just generalizing, amygdala, hippocampus, and thalamus. And then how about psychosis? This is a little more specific. So with psychosis, it's your prefrontal cortex, your ventral tegmental area, and your nucleus accumbens. And I'll get into more of that when I get down to the dopamine pathways. Right. All right, so neurons, nerve cells. We have 1 billion at birth, 100 billion at birth. Glial cells are the most abundant cells in the central nervous system, and they help form myelin sheaths. Myelin sheaths are essentially like a protective kind of fatty shield for neurons. And we've got 4 types of glial cells. They all do kind of different things. And then gray matter is nerve cell bodies and dendrites, and the white matter is axons that are myelinated. The frontal cortex is the last place to myelinate, and we know that the prefrontal cortex is responsible for reasoning, planning, judgment, executive decisions. And this is why teens make poor decisions, because their prefrontal cortex is not completely myelinated yet. All right, so neurotransmitters. You've got cholinergics, monoamines, amino acids, and peptides. And neurotransmitters work by opening sodium or chloride channels. Sodium causes cell depolarization, chloride causes cell hyperpolarization. And drugs affect neurotransmitters by either blocking a receptor, stimulating receptor, blocking reuptake, blocking metabolism, stimulating release of neurotransmitters, stimulating the affinity for receptors, or they block or stimulate not a receptor. So they do lots of things. So serotonin, it's synthesized in the raphe nuclei, which is in the brainstem. And 90% of your serotonin is synthesized in your gut, which is why a lot of antidepressants cause GI side effects. The serotonin in your GI tract is known as peripheral serotonin, and it's produced by enterochromaffin cells, which is why IBS is really common in anxiety. And serotonin production via enterochromaffin cells can be altered based on gut microbes. And a lot of newer literature is talking about the importance of the connection between the gut and the brain, and how the foods that you eat can impact the microbes, which in turn can impact depression, anxiety, etc. MAOIs block the breakdown of serotonin via the enzyme monoamine oxidase. TCAs block the serotonin reuptake pump, and they don't selectively block serotonin, which is why they have so many side effects and interactions. And then the SSRIs selectively block serotonin reuptake. All right, so this is like a really, really basic, overly simplistic way of thinking about how serotonin works. So when you have more serotonin, you have less depression, less anxiety, less headaches, increased sexual dysfunction, and increased temperature. If you have low levels of serotonin, then you have increased depression, increased suicidal thoughts, increased aggression, increased obsessions, increased anxiety. All right, norepinephrine. It's synthesized in the locus coeruleus, which is in the pons of the brainstem. And it is slowed, the release of it is slowed during sleep and increased during wakefulness, and kind of spikes during fight or flight response. And it helps with attention, concentration, memory formation, memory retrieval, and alertness. And this picture is kind of the flow in your brain. And the person who used to teach psychopharm, his name was Norm Keltner, and he was a very brilliant person. And the way that I remember where norepinephrine is synthesized is because Norm was loco, but he was cool. That's how I remembered it. I made little like acronyms and little mnemonics for a lot of things. Unfortunately, I don't have one for all of the serotonin receptors or the CYP450 enzymes. And so again, a really simplistic way of thinking about how norepinephrine works. Dopamine. This is probably my favorite neurotransmitter, if you can have one of those. So you have 4 dopamine tracts in the brain: the nigrostriatal, mesocortical, mesolimbic, and tuberoinfundibular. So in this picture here, the red is the nigrostriatal, the green is the mesocortical, the blue is the mesolimbic, and the pink is the tuberoinfundibular. And so how I remember what causes what is, so that the nigrostriatal is what causes EPS and tardive dyskinesia when you have decreased dopamine in that tract of your brain. And the mesocortical, when it's decreased, leads to cognitive symptoms, affective symptoms, and negative symptoms of schizophrenia. which we don't really have a great treatment for as far as negative symptoms. But the way that I remember that one is cort is negative, so mesocortical is negative symptoms of schizophrenia. Mesolimbic, when that's increased, that's what causes the positive symptoms. The way that I remember this one is when you're doing the limbo, you look crazy. So limbic, positive symptoms. Tuberoinfundibular is what causes the gynecomastia, hyperprolactinemia that nobody wants. And I remember that one because tuberoinfundibular tract causes tube boobs, however you want to say that. That's how I remember it. I don't know if that's helpful for you guys, but during my class of 8, there was only 8 of us when I went through the nurse practitioner program, and we all came up with these together. All right, okay. Can you guys tell me some of the positive symptoms of schizophrenia? Oh, good, I'm glad those are helpful. Hallucinations, delusions. Yeah, you guys are all saying the same ones. Paranoia, disorganized thoughts, disorganized speech. Yep, ideas of reference, racing thoughts, psychomotor agitation. How about some of the negative symptoms of schizophrenia? Yep, anhedonia, blended affect, concrete thinking. Thought blocking, social withdrawal, psychomotor retardation, poverty of speech, catatonia. All right, so I know that you guys know that typicals and atypicals have certain side effect profiles that go with each of those classes. So typical antipsychotics are strong D2, have strong D2 antagonism, which we know leads to more EPS, and they have strong CYP450 metabolism, which leads to interactions with other drugs and also grapefruit juice. And so if you have a patient on any medicine, just tell them not to drink grapefruit juice. Also, it's nasty, in my opinion. And so with high potency antipsychotics, they are slightly anticholinergic, minimally sedating, they have more weight gain and higher risk of EPS. Low potency are more anticholinergic, they are very sedating, have more GI upset, and cause bradycardia. With the atypicals, you have less risk of EPS and higher risk for metabolic side effects and weight gain. And they bind to D2 receptors like the typicals do, but they have a higher affinity for serotonin receptors as well. All right, again, oversimplified. Explanation of dopamine. And just to throw this out there so that you know, compazine, which is an antipsychotic, is often used for nausea and vomiting because it's a high potency and it's actually 10 to 20 times more potent than thorazine is. But I've seen a lot of ERs use compazine instead of like Zofran or Phenergan. All right, acetylcholine. It comes from the nucleus basalis of Meinert. Hate it, gave me akathisia. Oh no! For a migraine. Yeah, I've had that medicine once, and I also didn't have a good experience with it, so I don't really recommend that over Zofran or Phenergan. But all right, so acetylcholine is synthesized in the nucleus basalis of Meinert. how I remember that is that miners mine coal. So acetylcholine, minert. That's how I remember that. It's associated with learning and memory, and damage to these pathways are associated with memory deficits and dementia. Acetylcholine is a neurotransmitter used at the neuromuscular junction. So it's released by motor neurons to activate cells. So it's excitatory at the neuromuscular junction and skeletal cells, and it's inhibitory in the heart cells, which is why way earlier in the presentation I was saying that it kind of depends on if it's inhibitory or excitatory. And with this slide, so you have nicotinic acetylcholine receptors and muscarinic acetylcholine receptors. And this diagram kind of shows how they work in skeletal and heart muscles. But the nicotinic has to do with skeletal muscles. And with myasthenia gravis, it occurs when the body produces antibodies against these specific acetylcholine receptors. And then with muscarinic, there's actually 5 types. And these are in the heart, and they trigger signaling pathways in the target cell that inhibits firing of an action potential. And again, very simplified way of describing how acetylcholine works. So you have too little acetylcholine in dementia and Alzheimer's, and you have too much in Parkinson's. Do you know the neurotransmitters involved in Parkinson's aside from acetylcholine? Yes, dopamine. I don't know if you guys cheated because he sent out the slides already, and that's on the next slide. But all right, so Parkinson's is an imbalance in dopamine and acetylcholine. And so you can either treat it by increasing dopamine, by giving dopaminergic medicines like those listed below. You can decrease acetylcholine by giving anticholinergic medicines, or you can do both at the same time. So these medicines don't cure Parkinson's, they just provide symptom relief and increased quality of life. Or you can do what Michael J. Fox did and have surgery on your globus pallidus. So with Sinemet, it's a dopa decarboxylase inhibitor. So it helps more levodopa enter the brain. And high protein decreases the effects of levodopa because proteins compete with the transport system. And then with Requip, Mirapex, Permax, and Parladel, those are dopamine agonists, so they mimic dopamine. And then you have salicyline, which is an MAOI. It blocks MAOB, and it's neuroprotective, so it slows the progression of the disorder. MAOB is responsible for the metabolism and breakdown of dopamine. MAOI is responsible for the metabolism and breakdown of norepinephrine and serotonin. And then non-selective MAOIs inhibit the breakdown of all monoamines. So that's dopamine, norepinephrine, and serotonin. And then selective MAOIs only inhibit the breakdown of dopamine. I have never seen an MAOI used, nor have I ever prescribed one, but just so that you guys know, there's so many interactions with MAOIs. All right, GABA. Gamma aminobutyric acid. So like we said earlier, it's the main inhibitory neurotransmitter in the brain, and the main purpose is to reduce neuronal excitation. It's synthesized in the Krebs cycle, if you want to throw it back to microbiology, and it's a metabolite of glutamate, and it's highly concentrated in several parts of your brain: substantia nigra, globus pallidus, hypothalamus, gray matter, and the hippocampus. And it occurs in 30 to 40% of all synapses. Benzos enhance the effect of GABA on GABA A receptors. And caffeine has the opposite effect of benzos. They inhibit GABA release. And prolonged use of benzos results in an increase in the number of receptors and or sensitivity to GABA, which is what causes the tolerance and dependence. All right, very simplistic way of explaining GABA. All right, GABA and glutamate. So this is the Krebs cycle, just in case you guys didn't remember from microbiology. And it's a series of chemical reactions to release stored energy, and it's part of cellular respiration. It's also known as TCA or CAC. And like I said earlier, glutamate is also synthesized in the Krebs cycle. It's the main excitatory neurotransmitter in the central nervous system. It's also the most common neurotransmitter, and again, it occurs in over 90% of synaptic connections in the brain. And there's 3 main receptors: AMPA, NMDA, and metabotropic glutamate receptors. NMDA is really, really interesting. I don't know if you guys have read anything about NMDA, but they are kind of the most complicated of all the neurotransmitter receptors, and they're regulated by both ligand and by voltage, and they have at least 5 different binding sites: glutamate, glycine, magnesium, zinc, and a site that binds to PCP. And inhibition of NMDA activity plays an important role in how ethanol works in the brain and affects brain functions, which is essentially like the different stages of being drunk. They are also, the NMDA receptors specifically are very densely concentrated in the hippocampus, amygdala, and basal ganglia, and they're very vulnerable to glutamate excitotoxicity, which causes damage and leads to nerve cell death. There's something really interesting called NMDA autoimmune encephalitis. And that's when antibodies to glutamate and GABA receptors cause brain inflammation. And I'm mentioning this, 1, because I think it's fascinating, and 2, because NMDA autoimmune encephalitis typically presents psychiatrically first. So it's something that would be good to keep in the back of your mind if you're really struggling to figure out what's going on with the patient, and may need to kind of look further into some of these things. So there's prodromal symptoms of headaches, flu-like symptom, upper respiratory symptoms, really just general kind of feel crappy symptoms. And those can present for weeks to months before full-blown disease onset. And this can, what does it look like? I will get there. There's a really great book called Brain on Fire by Susan Cahalan. And she was a writer for, I can't remember if it was like the New York Times or Time Magazine or something. But she wrote a book about her experience with NMDA autoimmune encephalitis. And they used to think it was really rare, but it's much more common than they initially thought. And one of the residents that I worked with at UAB actually had a patient that was 18 or 19, New York Post, thank you. And come on to the unit at UAB that actually ended up having autoimmune encephalitis. And it can acutely cause memory deficits, amnesia, disorientation, seizures, Capgras delusions. Do you guys know what those are? Somewhere on a shelf.
You don't recognize your family or your friends, right?
Yeah, so Capgras delusions is when you think everyone is imposters, like your mom isn't really your mom, which is also a very interesting concept. It can also cause agitation, paranoia, psychosis, changes in speech, and it can also cause catatonia. It's highly comorbid with ovarian teratomas, like 50% of the cases have ovarian teratomas. It can also cause autonomic dysfunction, hypoventilation, and cerebellar ataxia. So what you'd want to look for is do an MRI. Unfortunately, they're normal in about 50% of the cases. EEGs are typically abnormal. And eventually, like, you would want to refer to neuro and really collaborate with them if you have someone that you think has this. Because we don't do lumbar punctures, but that is one of the tests that you would do. Did someone have a comment? Okay. Yes, CSF is the most sensitive. Yeah. So the CSF is positive for lymphocytic pleocytosis and elevated protein, as well as oligoclonal bands. And 75% of cases present to mental health before any other specialty. 75%, that's a lot. Unfortunately, if you treat someone with this with antipsychotics, they can later have symptoms that one would think would be NMS, but it's actually symptoms of the autoimmune encephalitis. And it's treated with IV, IgG, corticosteroids, and plasma. 75% usually recover back to baseline. There is a mortality rate of about 4%. But if you're at all interested in more about this, I would definitely recommend the book Brain on Fire. And again, very simplistic way of looking at glutamate. Some need plasma exchange. Yep, they do. All right, does anyone have any questions about anything I went over? Any questions about anything I didn't go over? Any questions in general? Is the temporal lobe involved at all in psychosis? Yes. Let me go back to, actually, let me escape out of this.
So
do you want to speak more to that?
Well, while you're looking up what you're going to look at, I just was thinking out loud here. So yes, there tends to be like a hyperactivity. If you're thinking about it in terms of functional connectivity, things like that, at the temporal parietal junction. And of course, your auditory cortex is part of the temporal lobe. And what you're going to see there is going to be some cortical thickening, which tends to actually show atrophy sort of at your auditory cortex. And it makes it difficult for you to actually get extinction within your auditory cortex. So it's almost like an echo chamber in your auditory cortex is kind of one way of looking at it. And it's very difficult to extinguish. So in the same way that PTSD people have difficulty with fear extinction, you can almost look at it as if people with schizophrenia have a difficulty with sort of internal voice extinction, if that makes sense. But yes, it is certainly involved.
Anyone else have any questions? Hopefully this was somewhat helpful to you guys and not just a review of everything you already knew. But
Do you think the typical antipsychotics are over. Do you think that efficacy is better in general for treating psychosis than the atypicals, since they are stronger dopamine agonists?
I mean, one of the things that you have to consider with typicals versus atypicals is, their diagnosis, how impairing it is to their life with these hallucinations. Because some people have hallucinations and they don't really bother them. Other people are very scared of hallucinations and they don't leave their house because they're very paranoid about them. So I would say that kind of depends. Really, symptom presentation, it depends. And then, if they've had EPS or if they have tardive dyskinesia. I mean, I feel like there's so many factors there that I don't have like a really great, just one word answer for you.
I mean, that makes sense. I just wondered if overall they had the efficacy in treating the symptoms was better in general, but
I would say in my experience that my really, really psychotically sick patients usually have better results with typicals than atypicals. But then again, you really have to monitor EPS and do AIMS vigilantly, and have, cogentin or Benadryl on board. I don't know if you guys have ever seen like significant tardive dyskinesia, but you can YouTube some videos. If you've never seen truncal gyrations or oculogyrate crises, they are pretty interesting.
I also hear that the atypicals are neuroprotective, and that the typical, I mean, they're neuroleptic. So I'm not completely clear what this means. Like over time, are they actually besides tardive dyskinesia, besides creating a propensity for tardive dyskinesia, are they also like actually destroying brain cells?
Chance, do you have an answer for that one?
So related to the atypicals, I don't know if I would say neuroprotective, depending on how you're operationalizing that. However, there is not long-term cognitive effects associated with atypicals. So that piece is true. In terms of the first generation, it's questionable with Haldol. It came out a long time ago, and it's gone through a bunch of different phases where it's been good, it's been bad, and the longitudinal studies suggest that Haldol may not have long-term cognitive effects, but things like the lower potencies, your thorazines, do. And can anyone maybe think as to why? First off, you'd have to know the difference between a high potency and low potency first generation, but can anyone think as to why low potency antipsychotics may be associated with more cognitive and long-term effects?
I kind of hit on it earlier. It was actually when I was talking about this slide that's pulled up. So with high potency, they're not as anticholinergic as low potency is, and they're more sedating. And another consideration about cognition with typicals is that usually you're going to have cogentin or Benadryl on board too, and those are also anticholinergic. And we know that those aren't really great for cognition either. Did you have another point to that though, Chance, that I didn't just say?
Oh no, it was mainly. I mean, anytime you're dealing with agents that have higher amounts of antihistaminergic and higher anticholinergic activity, you're going to inherit cognitive issues, which in part was why paroxetine was considered to maybe have some negative returns on cognition long term. It's evidence is kind of mixed depending on what you look at, but because it hits on those receptors relative to the other SSRIs, so there's a little bit more anticholinergic, there's a little bit more antihistaminergic. That was why they thought that it had more cognitive or negative cognitive outcomes. So that's one way to kind of look at it and maybe determine whether or not it's going to have long-term effects. Most of the time, it's going to be generated by antihistamine and anticholinergic, though that's an overgeneralization. Does that make sense? And maybe you already said this, Andrea, but if high potency first generations have less antihistaminergic and less anticholinergic, and low potencies have more, which one of those do you think has a higher incidence of EPS?
Yep, high potency. Anyone else have any other questions or comments or interesting things you've seen in clinicals recently?
Hello?
Hello.
Hey, my clinical instructor was just telling me the other day, we had a patient who came in with tardive dyskinesia, and he was telling me that back in the day, what they used to do, the patient was on a first generation antipsychotic, can't remember which one specifically. But anyway, what they used to do back in the day was increase the dose to make the side effects go away instead of like taking it away, instead of, decreasing the dose or taking the medication away, and I thought that was interesting.
So just
Yep.
to jump in there, that only works and lasts for about 6 months to a year. So you're just buying a little extra time with that.
Right, which is probably the reason they don't do it anymore.
Yeah.
But he was just saying that's what they used to do.
Yeah.
And I was like, oh, that's weird. I've never heard that before.
Well, and that's also the
Yeah.
same logic whenever you have someone on an antipsychotic, and then, if we're just looking at EPS as sort of an isolated case, that's why sometimes you see people add an additional antipsychotic, is because temporarily you can actually reduce tardive dyskinesia, again, for some period of time.
Yeah, and he was actually saying that that some of the patients would report that, like, if you did decrease the dose, then they're more aware of it, or they're more aware of those side effects, which was interesting too. So, but anyway,
Yep.
I just wanted to. I was just.
Yeah, sometimes when you're tapering off of an antipsychotic, they can also have kind of a relapse of EPS symptoms. Kind of the same concept there. So if you restart it, typically those decrease.
In a slower taper, you can usually avoid that.
Right, which we always want to do. I guess the only exception to that would be maybe if they're having NMS.
Right. It's kind of like the mood stabilizers, like the rash, like say like Lamictal or something. If they're having a rash, you're probably going to want to taper that a lot faster than you would normally.
Right.
Yeah.
I actually read about that, what you were just talking about, is a strategy for somebody who's like attending a wedding or something. If they have a TD, that you can up their dose a little bit during that time frame. So, while they're being videoed, they aren't doing their mouth movement or whatever it is. So.
So just a quick, this is just a general question, but if someone has tardive dyskinesia, do we use anticholinergics?
you might not be able to see if it's getting worse, I think.
Yeah, I was just asking generally. So if you have someone with TD, I mean, is the treatment for that anticholinergics?
No.
It's
I think we had talked about Artane, just going off the top of my head. Let's see, which is an old, this doctor likes to use old things.
This is going to give us a bunch of crushed rock.
Yeah, in theory, you should get them off anticholinergics. I mean, they're for all purposes, they're contraindicated in people with tardive because it can actually make it worse. There's a conversion, the imbalance between acetylcholine and dopamine. It switches to sort of an irreversible state where if you continue to kind of bring down the acetylcholine, which in some cases could actually boost dopamine, it's no longer able to do that, and you can actually make it worse and inherit more motor symptoms. Though you still see a lot of people with TD that are on things like cogentin and Artane or trihexyphenidyl, I think is what you were referring to.
I was wondering if you could explain kind of mechanism of action of Ingrezza for TD.
I don't actually know much about that medicine because I work at the VA and we work on a formulary. But I would be more than glad to read more about it and get back with you on that unless Chance knows.
So, and I mean, and I don't know a great deal about it, but so the prototype for it is, and maybe you guys have heard of this, is tetrabenazine and reserpine. You guys have heard that name or those two names before? And they're pretty old, so maybe Gloria's doctor, he probably still, our collaborator, he may really like those. But have you guys heard of tetrabenazine, reserpine? Okay, yeah. So tetrabenazine is actually, it was effective for TD for the most part, but the side effects were terrible. And one of the things that is interesting about the VMAT2, which is what the main mechanism of action for Ingrezza, is amphetamine is actually a tetrabenazine site, whereas I think methamphetamine is the reserpine site, and those bind to the VMAT2, so they inhibit its function. And so if you think about amphetamine, what does it do with dopamine? So if you take amphetamine, what happens?
Increases the dopamine.
Yeah, increases dopamine, right? And what causes, in theory, now again, there's more to the story, but what causes things like EPS?
Isn't it? It's like too much acetylcholine. There's no balance between the dopamine and acetylcholine.
So there is a balancing act, and acetylcholine plays a significant role here. But relative to dopamine, is it increased or decreased when people experience EPS?
Look at the slide, guys. It will tell you.
So a decrease.
Yeah, it's decreased. So if we know that amphetamine works on like the tetrabenazine site and methamphetamine works on the reserpine site to inhibit its function, then that would mean that they have to inhibit VMAT in order to produce dopamine. So Ingrezza blocks VMAT in order to reduce dopamine. Does that make sense?
Mm-hmm.
And when it does that, if you inhibit the VMAT2, which is something that, like I said, amphetamines do, then you get like excitosis, you get action potentials, you get specifically monoamine, which is, I think Andrew had talked about that earlier. So like your epinephrines, norepinephrines, dopamines, they're actually almost rerouted when you inhibit them. So they're not released into the synapse by a typical release. So it's actually gone through a different action potential change. So it's pretty strange in terms of the mechanism. And cocaine does something at VMAT2. I'm trying to remember. If I remember right, cocaine users have like maybe reduced VMAT, an immune reactivity, something about immune. Anyway, I'm thinking out loud here. But they think that the VMAT and the reduction of that is the reason why cocaine users actually have a lot of mood disorder symptoms, while they demonstrate more more inflammatory mechanisms like cytokines, and they have more motor relative to some of the other substances, because there's damage to the striatum via cytokine signaling, and that's more than you need to know. But just remember, inhibiting of them, that increases dopamine, and that blocking it, inhibiting increases, yeah, and agonizing it decreases, if that makes sense.
Thank you.
All right, any other questions? Well, if you guys think of any questions, or if you're like reviewing the slides that Chance emailed out and have questions, please feel free to message me and I'll be glad to answer them.
And I mean, I'm here until 7:30, since that's when it was running too, so I'll hang around.
Oh, I'll be glad to hang around too. I was just, saying.
So I work in the community mental health system, and most of my patients experience polypharmacy, and it's hard for me to know, like, whether or not it's ethical and appropriate. Like, everybody's afraid to take off something if someone's had a lot of difficulty being stable and they've sort of earned all of these medications. So it's hard to know. They're on like 6 different, a mood stabilizer, a couple of antipsychotics, and then, medication for sleep, another one, an anticholinergic. It's not really a question. It's hard to navigate, I should.
So, and Andrea can parse this any way she wants to, and it's hard to know, because every individual case obviously is going to have, a different need, or determine whether or not this is polypharmacy due to poor practice, poor prescribing habits, or if it's actually necessary. So with some SMI, it is sometimes unfortunately necessary for them to be on that many medications, at least in theory. One of the things that you run into, and you see it more often in places that are like 5 to 10 minute visits, when they do med checks, and basically you come in, you fill out a form that says what symptoms you have, and then you're given a medicine for those symptoms. A lot of times you end up treating the side effects to the medicine. So you're sort of chasing yourself in circles, and you end up at 5 or 6 medicines, and the person is so, either agitated or so sedated that it makes it difficult to determine, oh, was this person depressed? Do they need more medicine? What's going on? But the best way to figure it out is go back and look at how those medications were stacked, and if meaning, which one came first and second, and if the person did a decent enough job where you could, where they wrote out the symptoms they were experiencing when they came back, and, meaning the rationale for starting the second, you may be able to tell whether or not the first medicine was contributing to that. Maybe they got the first medicine wrong. And then they ended up treating not symptoms of a diagnosis or disorder, it was symptoms of a medication. And I know that's not exactly what you're looking for, but that is honestly one of the only places that you're going to be able to start initially. The other time is looking at combinations of meds. So if they're on 2 antidepressants, get rid of one of them. I mean, that shouldn't be the case. If you've got medicines that are working on the same neurotransmitter, say something like GABA, you've got Lamictal, you've got Ativan, and you're on gabapentin, and the person's showing a lot of negative cognitive symptoms, and they seem to have gotten worse. Some of the other stuff, maybe anxiety's a bit better, which happens in a bit, different area, say like the limbic, but the cognitive symptoms haven't really remitted. And every time there's a dosage increase or there's a change in one of those GABA agents, it seems to aggravate some of those negative cognitive symptoms. the person probably has too much GABA. And in that case, you need to look at strategies to try to maybe reduce some of the GABA medications. And again, that's a more of a pure example, but that's one way to do it. You just kind of have to know what the symptoms are that are associated with the neurotransmitter of interest. And if there's a bunch of medicines that are, for whatever reason, converging or primarily affecting that, and that's what you anticipate when you agonize that, something like, amphetamine and dopamine. So if you have a lot of dopamine, you become psychotic. So if the person's acting kind of psychotic, they probably have a lot of dopamine, among other things like glutamate. But we recognize that, so then we treat it. So you're still doing the same thing, but even the best of biochemists, even the best psychopharmacologists probably don't know what more than 2 medicines are doing in combination. When you get to about 3, it's a lot of guesswork. So you want to simplify it where you can.
And one thing I'll add to that is that you need to be mindful of, like he was saying, if some of the additional medicines are not causing more symptoms. Like if you have someone on gabapentin and Ativan and they're starting to become more depressed, it might be a side effect of the medicine instead of like an actual true depressive episode.
That's right. So you want to try to target one of those GABA agents, whichever one makes the most sense relative to the rest of their profile. But yeah, I mean, if they weren't having cognitive before, but then when you started adding, because neurology will add something, cardiology may add something, you'll add something, and also when they come back, they have a slightly different presentation. Try to see what was added, try to see what changed and what was different. It is environmental, it is other things, but it's also on the medical side. Was there additional medication added and everything was okay until that was done? Say, I'm making this up, but say they were on venlafaxine and the pain rehab decided to throw on a tramadol. And now they're talking about kind of feeling dizzy, getting migraines and headaches or something like that, but they weren't having those beforehand. A lot of people are like, oh man, it's the venlafaxine, it's too high, which could be the case. But if you add something like a tramadol to a venlafaxine, what could happen? What is one of the things that we worry about? So serotonin syndrome, yeah, you worry about an increase there. And then also, oddly enough, the combination of venlafaxine and tramadol too, you actually lower the seizure threshold. So if this person was someone who had a TBI or had some other type of maybe neurological injury, you're changing the brain activity. And when you do that, you may induce, even though it doesn't reach seizure potential, you may end up inducing neurological-like symptoms. And you start reacting to that, adding other medicines, making changes. But it was really probably, if nothing had happened, up until that point, it was probably the tramadol. And either you change it on your end, or you communicate with the pain clinic or whoever put them on there about your potential concerns. Does that make sense?
I just heard something about this on the radio, and they're talking about the same thing, how medical medications in general can cause some psychiatric symptoms, like beta blockers was one they said can make people depressed and things like that. And
Yeah,
it's kind of interesting that we're talking about it.
Yeah, there was an article a coworker actually sent me, one of the social workers I work with, she was like, did you know all this? And so one of the list was like PPIs, a lot of blood pressure medicines, including beta blockers, and I can't remember.
Right. Yeah, PPIs, I remember that. Protonics was one.
Yep. Yep.
PPIs
actually have a lot of nasty side effects, including increased risk of what?
Like long-term use contributes to dementia in theory, yeah.
Well, yeah, dementia and, low calcium, because it changes the way you absorb calcium, and then it leads to osteoporosis. And there was a research study a couple years ago that was looking at PPIs in infants, because they started giving PPIs a lot to kids with really bad reflux. And they had like a 75% increased risk of broken bones in infancy and toddler age.
Another, and just sort of in that same vein, we're just having kind of a discussion, um, and feel free to answer. So, and if you've heard this, I apologize, but does simvastatin on its own cause an increase in glucose? You can just say yes or no. Would you anticipate someone being on simvastatin for it to increase glucose? Yeah, no, right? What about paroxetine, at least directly? Would we anticipate that glucose would go up on paroxetine? Right, we got a maybe and a no, and that's actually, both of those are pretty good. So no, not directly related to the medicine. Maybe though, over time, if you're eating a lot because it's has the antihistaminergic activity, then maybe. But as a direct result, no. But if you combine those two, there's something like 60 to 70% of people that are on that combination actually end up having a pseudo diabetes. Their glucose will go up. And a lot of people, they can't explain it. They end up getting, sometimes on metformin or things like that. And it seemingly is just medication induced. So if that happens, if someone comes to you who, is reasonably healthy and they were on simvastatin and you add something like a paroxetine, they say, you know what, I just feel like I'm thirsty all the time, or, things that we would in any other setting would say, oh yeah, well, have you checked your blood sugar? Check the blood sugar. And then you may want to make a change. Now, the turn of that is that paroxetine may be the exception with that. There's some case evidence that it happens with other SSRIs, but combining SSRIs and simvastatin has also shown to be pretty effective for severe depression. So there's still some things that have to be worked out. So there are pros and cons sometimes to combining medicines, but I just thought I would throw that out there because it happens a lot more than I think people recognize.
One more thing, just talking about polypharmacy in general. We had a patient the other day who was on a lot of medications, and sometimes if the patient is, with it enough or has enough insight, you can kind of ask them like, well, which ones do you feel like are really helpful and which ones aren't? And, a lot, it seems like too, the patient's perception of the medication matters. So even if, it could be a super amazing drug or whatever, if the patient thinks it doesn't work, sometimes if there's a lot of medications going on and the medication doesn't make sense and the patient doesn't think it works anyway, then it's like, oh, well, good, we can maybe get rid of that one. I don't know.
It's interesting you say that. There's I don't know if this is published or not, but there's a group of psychiatrists that I met at a conference, and they were talking about something similar. I mean, and one of the things that I tell patients is you know your body better than I do, so you tell me kind of what's going on, and really part of our one of our main jobs is basically just giving them a language to communicate with us. But one of the things they said is that if you ask a patient which one of those medicines is working the best without giving him information, they just react instinctively, that they can usually determine very quickly which one is not effective or the one that they think is the most effective. But if you start giving them a bunch of information before you ask that question, then their ability to be able to detect which one is actually causing those problems goes way down, which again, I don't know if that's true, but it does make a lot of sense because our bodies do a lot of stuff in the background unconsciously, and it knows when you introduce something that is not good for it, but it may not be able to, push those signals or that recognition up to your more cortical areas of places where you can, access it and repeat it. But
Right.
I thought it was extremely interesting.
Yeah, I kind of learned that from my inpatient preceptor. He asks just about every patient, well, like on their intake, what medications have you taken in the past? And I mean, I know we all do this, but, was there one that you thought was very helpful? Or was there one that you thought was really not helpful? And they kind of seem to know that. And even, when you're trying, because the other girl was talking about just trying to determine which ones maybe can we get rid of. I think, involving the patient in that conversation, like, hey, we have, and I mean, of course, we know what they're for, and maybe some of them that they don't like, they have to be on or whatever, but they might be able to kind of guide you and say, oh, well, maybe, you don't need this one. I was between these two, but you don't like this one, so we'll get rid of it. I don't know. And I find that usually it seems like the patient's buy-in is helpful and they seem to do okay. So I don't know.
Yeah. And it's a little different if you're inheriting a patient from another provider and they've come to you with all of these medicine trials. But if you're starting someone with kind of from scratch, then it's also really important when you're writing them a medicine to educate them about this is what we're looking for as far as improvement. This is what it's supposed to be helping with. And also, if you have any of these things, then you need to let me know too, and really actually discussing the side effect profile. It amazes me how many times people just write a script and say, hey, go fill this, let's see if it works, and don't really educate them on like what it's supposed to be doing and also potential side effects that it could be causing, because that's important for the patient to know too. Because if you come back and say, hey, well, are you having any side effects? Well, I don't really know what to look for, kind of thing,
Right, exactly. It's funny you say that too, because my outpatient preceptor, he will, working with the kids, he'll say, this medicine is going to make you feel less anxious, or this medication, whatever it's for. And he'll tell the parents, tell them that, and so they have like that expectation of it. And so, it's just kind of like the medicine is supposed to do that anyway, but if you also have the expectation, it's kind of like maybe it'll work better type of thing. I don't know.
Well, and going back to kind of what I was saying earlier and what you guys have sort of reiterated is that we give them a language to communicate with us. And so sometimes people who are depressed, I mean, just by dint of the cognitive impairments that are inherited within depression, they're going to have a harder time being able to sort of abstractly talk about what they're going through. In fact, they may not be able to give you anything that's necessarily of value. A lot of their responses can be, I don't know. But if we're educating, like Andrea was saying, you were saying, if we tell them these are the things that we expect to happen, this is what we want to improve, and you're not giving them just a list of stuff, 30 things. You're giving them very pointed, very 3-4 things to hold on to. Well, they will actually, just because they're deliciously human, they will focus on those 4 things, and they will be looking for. It's like, well, nope, they didn't improve. You said they might, but they didn't. Otherwise, if you're just giving them all this other stuff, you'll find a lot of them don't really know what to tell you. They don't really know how to internalize it and then again feed it back to you externally. And the same thing with side effects. I hear people just read off a bunch of stuff. They're not going to remember that. They have no idea what to do with it. But it's selective education. Here are the things that you really need to be looking for.
Right.
And you must take this with you. Here are the things that could happen, but they're pretty normal and they'll probably go away. But if they don't after a week, that's when, or 2 weeks, that's when you need to call me. And that's what they're going to hear, right? So we just be very, very selective and pointed with what we tell them.
That same preceptor, he refers to Occam's razor. Have you heard of this? It's where you basically pick out the most important piece of information that you want them to know and you focus on that. Just like what you're saying. It's very focused. It's not 1,000 whatever. It's like, this is the 2 things I want you to remember, and that's it.
Yeah. And it's also not very helpful, just from a patient's perspective, if a prescriber hands you like a fact sheet about a medicine that says, hey, this is what this medicine does. Let's see if it works and come back. Because then there's no dialogue there. And some patients don't actually take the time to read it. It might not be at their education level for them to understand what's going on. So again, another reason why like the conversation there is important. I found the article that we were talking about. 200 commonly prescribed medicines can increase depression. And if you're on 3 or more that have a potential side effect of depression, your risk for depression increases by 15%. And it was listing beta blockers, blood pressure medicines, birth control, antacids, and painkillers.
Yeah, so painkillers are an interesting thing. I don't know if you guys are aware of this or not, but it's just some additional information since we have a few minutes. But do you guys know what the new wave of, I mean, outside of like your ketamines, your AMPA and NMDAs, do you know what the new wave of antidepressant medicines that are in trial right now, do you know what they target? So they're a lot of them are going to be opioid based, because they have found that combining certain antidepressants with things like Subutex actually improved a lot of people's depression. So they've got a couple that are in the works right now that are going to be targeting mu, delta, kappa, which is, I mean, it's interesting. But if we think about some of the mood effects that come along with things like, Lortabs, whatever, I don't know. I mean, it's because we're doing that in practice anyway with like SSRIs and Lortabs, but at least my personal experience is that combination doesn't tend to be very effective. In fact, for people with PTSD, I find it to be harmful when they're on opioids. So I don't know if they're targeting it with some type of treatment-resistant depression, trying to combine with opioids. But anyway, I just thought I would share that. I mean, there's a lot more to that, but I don't want to waste you guys' time. But be on the lookout for opioid receptors medication.
Well, and then there's like the newer medicine Contrave that mixes bupropion and naltrexone. That's used a lot for like weight loss or food addictions or any kind of generalized addiction with the naltrexone.
Right, and it does depend. I mean, so if you as an example, so if you agonize something like a mu, say with like a beta endorphin or a enkephalin, I mean, you can increase mood and get euphoria with that, which is part of the reason why people abuse opioids. And the same thing with delta. I think somebody may have to correct me. I think enkephalin is an agonist at the delta receptor, but it's anti-anxiety, increases mood. But it's the kappa, if it's inhibited, or excuse me, if it's depression would inhibit kappa. That's right, and that's where they think that you're getting dysphoria and maybe PTSD symptoms is at that kappa. So I wonder if that's the target. But painkillers like Lortabs or whatever, they do hit kappa. So I would think, and again, I'm not sure how all this is going to roll out, I would think that they're going to try to avoid or block like something like a dynorphin A, which actually causes dysphoria. So maybe they block that. Maybe they, I don't know. Anyway, I just was throwing that in there. But mu and delta, if you agonize those two, that's a good thing.
What do you think of ketamine?
I think there's a lot more research that needs to be done about it. And do you guys know the absolute contraindication for a ketamine trial for a patient?
Somebody with psychosis?
Yes, any history of psychosis is absolutely contraindicated.
So,
yes.
I mean, I'll say this. I think the early work on ketamine, again, in shorter trials, seems to be promising. The delivery mechanism is going to have to be fixed, because most of what they don't tell you is that a lot of the trials they do is actually IV, and you're getting it multiple times in a week. And so there have been studies that have shown the potential for short and long-term effects, and I think that's valid. But there's also a subset of people, if I'm depressed and I've never had cocaine before, and I snort a lot of cocaine, I'm probably not going to be depressed. I'm probably not going to be suicidal within the 30 minutes or so that I'm high on cocaine. And so there is going to be a euphoria effect, because that's the main reason why it was thrown in, is like, oh yeah, it can reduce acute suicidality. Well, yes, but it could be based on immediate euphoria that doesn't last. And that's what they have to figure out, because the way they're administering in most cases is IV. You can't take that home with you. I mean, that's not going to be a sustainable way to get treatment. So they're still working on coming up with a pill that can duplicate kind of those same effects. But the mechanisms, the AMPA, the NMDA, the rebalancing of sort of the glutamate GABA, ultimately what they're targeting is the TRK receptors, which is to promote BDNF, which is really what they think a lot of the benefits from SSRIs are over time. When they're starting to work 3 or 4 months later, they think it's because the BDNF system has come back online, whereas ketamine is apparently able to do that immediately. So it has neurogenic properties almost instantaneously. And that's what makes it so appealing, is you can knock off months of really trying to get at that BDNF production, if that makes sense. But like I said, there's a lot of things they're going to have to work out in terms of delivery. It's also an mTOR signaling pathway, if you guys have heard of that. I don't know if you're familiar, so I don't want to take you down that rabbit hole, but that's one of its main pathways.
What do you think of CBD or cannabinoid? I pronounce it wrong, I think. But the other part of the marijuana, not the THC, but the CBD oils. A lot of my clients use CBD oil.
Well, one of the problems with that is that there's no regulating body for them, so you really don't know what you're getting. So if you buy one brand, it might not be equivalent to another brand. And then, I mean, that really varies as far as response and symptom reduction. So
yeah, I think, and this is general, and this is only reading certain things that I don't use it in practice. And again, practice is much different than what you read. And I think there's also, how you fall on the whole marijuana thing in general. I think that for certain, and I don't think we're there yet because we're not able to be as specific as we need to. But I think that there are certain strands for certain people, for certain disorders of marijuana that are probably effective. The smoking of it probably, actually obviously is a bad thing because the inhalations create anoxia, so you're going to get some negative outcomes there. But if you could, deliver it, specific strand, purity, potency, all those things were predictable, as Andrea is saying, I think there's going to be people that, yes, it will be effective for. Will that effectiveness last long term is kind of the question, because what they've shown is that even for people who respond well to some medical strand of marijuana, that they do tend to experience some level of cognitive effects. Now, the one good thing is that after about a month of being away from it, those things tend to rebound. But there's just not enough evidence to say whether or not there's long-term effects related to each and every one of those strands. So there's a ton of research that's needed. With the general impression of that oil is that it's effective, but that's also sort of grassroots, where people who are not using controlled trials, they're not using, as again Andrea is saying, the same types of oils. There's no way to test in some of these cases whether or not it is actually what they say that it is. So there's a lot of things that it needs to be moved into pharmaceutical regulated trials before we can say absolutely. But I mean, there's a lot of positive, feedback, and a lot of people are using it over the counter and buying it on their own, and they swear by it. But kind of like the cocaine thing, there is sometimes a difference between the short-term effects of stuff relative to the long-term. So cocaine may make you feel great and euphoric your first year of using it, but after that, things begin to turn on you a little bit. So I think longer studies are needed, but it's certainly promising. Is there any other questions? And whoever that was that asked the marijuana question, we can go offline sometime and talk about it if you want to.
Good. I'm glad it was helpful. I appreciate you guys for being so interactive. I wasn't sure how this was going to go.
Yeah, Darby, I recorded it, so I'll just have to upload it. But I have to convert it first, and sometimes that takes a couple hours.
In the files of the VC. I don't know what that means. Oh,
Oh yeah, yeah. I'll convert it and then I'll send it to you guys. Were you guys able to access the note writing one? Did it pull up okay for anybody that's in here that pulled it up? Because it will be the same. Okay, it did. All right. So yeah, I'll do the same thing.
Chance emailed out the PowerPoints as well. If you guys didn't get it for some reason, message me through the course and I'll be glad to send it to you. Yeah, I plan to do one on mood stabilizers. We haven't set up a date for that though. Did you want to do a doodle poll to figure out when would be best for
Yeah, we can do
everybody
that.
to do one? Okay.
And I think someone had requested antipsychotics and long-term injectables.
Oh, the
So
LAIs.
yeah, so if that's something that you're interested in, we could talk about maybe setting something like that up. It could be a bit shorter or something like that, but it was requested.
Okay, sure. Yeah, I can work on that. All right. Thanks, guys.